So imagine for a second that you are tasked with hanging a hammock in your backyard.
Okay, I'm picturing it.
But there is a massive catch here. You have to do it in pitch darkness. You can't exactly see where the trees are,
Oh,
right?
no. Yeah, that sounds like a nightmare.
And it gets worse. If you accidentally nail the hook into the wrong spot, say, like a water pipe running down the trunk, you are going to cause a massive catastrophic plumbing disaster.
Right. I mean, that sounds incredibly stressful. You definitely want a very precise, foolproof map of the yard before you even, picked up a tool.
Exactly. And welcome to today's deep dive. We are thrilled you're joining us because today we are taking on a really fascinating mission.
We really are.
Yeah, we've got a stack of surgical literature, anatomical charts, and medical history, and we are looking at a highly engineered medical question. What exactly is the structural difference between two kinds of surgical implants, a tension-free vaginal tape, or TVT, and a transobturator tape, or TOT, sling?
It's just a brilliant question. I mean, it takes us right into the intersection of human anatomy, physics, and, well, surgical engineering.
Right.
We're basically looking at how a shift in simple geometry changes absolutely everything inside the human body.
Yeah. And to set the stage for you, the listener, we are talking about a condition called stress urinary incontinence, or SUI.
Right, which is incredibly common.
Very common. And for anyone unfamiliar, this is basically the accidental leakage of urine that happens during physical activity. So we're talking about everyday things, right? Laughing, coughing, sneezing, or, lifting something heavy.
Yeah, basically any action that causes a sudden violent spike in intra-abdominal pressure.
Okay, break that down for us.
Yeah, so when you cough, your diaphragm slams down, right?
Yeah.
Your abdominal muscles contract, and all that pressure, it pushes directly onto your bladder.
And to fix this, surgeons rely on something that sounds surprisingly, low tech.
It really does.
It's just a tiny piece of synthetic material. Specifically, it's a strip of polypropylene mesh tape.
Right, and it's inert, it's stable,
Mhm.
and it's meant to just stay in the body permanently.
But before we get into the tape itself, I think we really need to understand what doctors were doing before this tape even existed. Because from the sources, it sounds like the historical treatments for this were essentially like major reconstruction projects.
Oh, they absolutely were.
Yeah.
I mean, historically, the focus was mostly on just trying to artificially hike up and support the bladder neck itself.
Okay.
So patients often face procedures like the Birch-Colpo suspension.
Birch-Colpo suspension, that just sounds intense. What does that actually involve physically?
Well, it involves making a pretty significant abdominal incision and then physically pulling up the front wall of the vagina and stitching it directly to the strong ligaments near the pubic bone.
Wow.
Yeah, it was a major invasive surgery.
Hmm.
And if they didn't do that, alternatively, surgeons were having to harvest the patient's own autologous tissue,
Wait, meaning what exactly?
meaning cutting a strip of the patient's own fascia, which is the tough connective tissue casing around muscles, usually from their abdomen or their leg, just to make a homemade sling.
So the patient wakes up with two completely different surgical recovery sites.
Exactly.
One where the sling was placed and one where the material was harvested. That means longer operating times, more time in the hospital, and a much more painful recovery.
Which is exactly why the introduction of a prepackaged synthetic mesh strip was such a revelation. But to understand why a tiny strip of mesh fixes this problem without needing all that major reconstruction, we have to go back to a major aha moment in medicine.
Right, this paradigm shift in the literature.
Yeah, it was called the integral theory of female urinary incontinence, and it was pioneered back in 1990 by two researchers named Petrus and Olmston.
So instead of just pulling everything upward and stitching it to the bone like a suspension bridge, what did Petros and Olmston actually propose?
They suggested that SUI is actually caused by a structural failure of the connective tissue in the vagina, specifically like a laxity in the supporting ligaments.
Okay, I'm trying to picture this.
Think of the pubourethral ligaments as suspension cables and the levator ani muscles at the base of the pelvis as the floorboards. Together, they form this physiologic backboard.
Ah, okay. So when those cables stretch out or the floorboards get weak, they just can't compensate for that sudden spike in pressure from a cough or a sneeze.
Exactly. The urethra gets pushed down, it has nothing firm to compress against, so it just sags open and urine leaks out.
So Petrus and Olmston theorized that if you place a synthetic mesh strip under the mid-urethra, it essentially acts as an artificial ligament, right? A neoligament.
Spot on. It reinforces that weakened backboard.
It's basically like building a tiny synthetic hammock for the urethra to rest against.
That's a perfect way to describe it.
But let's unpack this core question for you listening. If both the TVT and the TOT procedures are ultimately just creating these synthetic mesh hammocks out of the exact same polypropylene material, why do we need two different versions?
Right. It's a great question.
And how are they actually structurally different once they are inside the body?
Well, to answer that, we really have to start with the pioneer, the original tension-free vaginal tape, or TVT.
The one that started it all.
Exactly. This was the procedure that revolutionized the treatment of stress urinary incontinence. And its entire structure is defined by the route it takes through the body. It uses what is called a retropubic route.
Okay, let's translate that for a second. Retropubic means routing the tape behind the pubic bone, right?
Correct. So the surgeon makes a small incision in the front wall of the vagina, right under the urethra. Then, using these specially designed, long, stainless steel needles called trocars, they attach the mesh strip. They pass these long needles on either side of the urethra, going straight up, slipping behind the pubic symphysis, which is the joint connecting the two halves of the pubic bone, and the needles exit through two very small cuts on the lower abdomen.
Right, usually hidden right within the pubic hairline.
Exactly.
So if I'm picturing this three-dimensional geometry in my head going from the lower abdomen, diving down deep under the urethra, and coming straight back up to the other side of the lower abdomen, that creates a very distinct, steep shape.
It does. It creates a really deep U-shape right under the mid-urethra. The anchor points are high up in the abdomen, so it's pulling the mesh down into a tight U.
Which brings me to a major mechanical question that stood out in the sources. They call this tension-free vaginal tape. But if you are using this steep U-shaped sling to hold up a sagging organ, how can it possibly be tension-free?
Right.
I mean, if I pull a hammock tight enough to actually support weight, there is massive tension on those ropes.
Yeah, that is a very common point of confusion, and it is crucial to understanding the mechanics of the TVT. The goal is absolutely not to pull the urethra tight.
Oh, really?
Yeah, you are not creating a tourniquet that constantly squeezes the organ shut. The mesh is actually placed quite loosely.
Okay, so how does it stop the leaking if it's loose? That seems counterintuitive.
It only engages when it needs to. During normal activity, sitting or walking, the mesh just rests there, totally tension-free.
Right.
But when the patient coughs and that intra-abdominal pressure spikes, pushing the urethra downward, the urethra meets the mesh. The mesh acts as a firm wall that the urethra flattens against, sealing it shut temporarily.
I see. So it's a backstop, not a chokehold.
Exactly. It prevents the hypermobility without constant squeezing.
And because this came as a prepackaged kit and could often be done under local anesthesia, it became the gold standard almost overnight, didn't it?
It did. Patients got to skip the massive abdominal cuts of the older surgeries, which was huge.
But, and this is a big but, the path it takes to create that U-shape introduced a pretty terrifying problem. We have our hammock, but getting the ropes to the abdominal trees is, well, it's hazardous.
It's very hazardous. The major structural flaw of the TVT procedure is that it requires what surgeons call a blind passage.
Just hearing the phrase blind pass in a surgical context is enough to raise anyone's blood pressure.
I know, right? When those long stainless steel trocars are pushed up through the retropubic space, the surgeon cannot directly see what the tip of the needle is passing by.
So they're just guessing.
Well, they're guiding it entirely by feel and anatomical landmarks. But that retropubic space is not an empty hallway.
Right.
It is an incredibly crowded cavern. You are bringing sharp needles into very close proximity with major vascular structures, with the bowel, and most notably, with the bladder itself.
Which takes us exactly back to the analogy we started with. You are trying to thread a long hook through a crowded, dark room. If you bump into the furniture, the blood vessels, or the bladder, the consequences are severe.
They are. The sources point out that severe vascular and bowel injuries, while rare, are life-threatening when they happen. Bladder perforations, however, are much more common.
Really? How common?
The literature notes that bladder perforations occur in approximately 3% of TVT procedures. The needle literally punctures the wall of the bladder as it travels upward.
Wait, 3%? That is a massive number when you are talking about millions of these procedures being done globally.
It is.
How do surgeons even know if they hit the bladder if they can't see the needle?
Well, they have to routinely perform a cystoscopy during every single TVT procedure.
Okay, what's that?
They insert a thin tube with a camera up the urethra and into the bladder. They visually inspect the inside walls of the bladder to make absolutely sure they didn't accidentally poke a trocar through it.
Wow. And if they did?
If they see a puncture, they have to remove the needle, reposition it, and then let the bladder heal with a catheter for several days.
Goodness. So because bumping into that anatomical furniture was simply too risky, the structure had to evolve.
It had to, yeah.
If the upward path into the abdomen is a minefield of blood vessels and the bladder, I'm looking at the anatomy of the human pelvis, and the only other way to route this tape is to avoid going up altogether. You have to go sideways, out into the hips or the groin.
That is exactly the deduction that led to the next major breakthrough. In 2001, a French doctor named Emmanuel Delorme essentially looked at the pelvic anatomy and redrew the map.
Okay.
He realized the only way to eliminate the risk to the bladder, the bowel, and those abdominal vessels was to completely bypass the retropubic space.
So he went lateral. Tell us about this new route.
This is the transobturator tape, or TOT, procedure. Instead of navigating up behind the pubic bone, the sling is placed transperineally. The surgeon routes the mesh laterally, out through the obturator foramen.
Okay, for those of us trying to visualize our own skeletons right now, where exactly is the obturator foramen?
Right, so if you look at a model of a human pelvis, there are two large natural openings in the bone structure near the bottom, one on each side, sort of below, and to the side of the pubic bone.
Okay, I can picture that.
In a living body, these holes are covered by a tough membrane and layers of muscle. Delorme designed curved trocars that pass through these natural openings, pushing laterally through the muscle and exiting out onto the upper inner thigh, right in the groin creases.
Oh, wow. So instead of the needles poking out of your lower stomach near the hairline, they exit the sides of your upper inner thighs.
Exactly.
And structurally, that lateral side-to-side routing completely changes the geometry of the sling, right?
Right.
The TVT created that deep, steep U shape because it anchored high up.
Right.
The TOT is anchored wider and lower out to the sides, which must create a much flatter shape.
It does. It creates a distinct V-shaped sling.
Mm-hmm.
It's a much flatter, less arched angle than the TVT. And the sources note that this flatter angle actually mimics the shape and function of the pubocervical fascia much more closely.
The pubocervical fascia being the natural hammock of connective tissue that usually sits under the bladder and vagina.
Yes, it replicates that natural, shallow hammock of the pelvic floor far better than a steep U-shape does.
Now, here is where this gets incredibly interesting for anyone thinking about fluid dynamics. We are using the exact same polypropylene mesh tape.
Yep, same exact material.
But does changing the anchor points, shifting the geometry from a deep U to a shallow V, does that actually change how the patient pees?
Functionally, mechanically.
Yeah. Does the shape really matter that much?
It matters tremendously, actually, and the clinical difference is pretty significant. Because the TVT's U-shape is more arched, it physically hugs the sides of the urethra more tightly. It pulls slightly upward.
Right.
Structurally, that makes it far more obstructive.
Obstructive meaning like it acts like a kink in a garden hose.
That is a perfect way to visualize it. When doctors actually look at this on an ultrasound while a patient is urinating, you can visually see how that steep U-shape creates a sharper bend or compression on the urethra.
Wow, okay.
The sources highlight that voiding dysfunction and urinary retention, meaning the patient simply cannot fully empty their bladder because the hose is kinked too tightly, are slightly more common among women who undergo the TVT procedure.
So it fixes the leaking, but sometimes works a little too well and acts like a permanent clamp, making it hard to go at all.
Exactly. Contrast that with the TOT. Because it has that flatter V shape, it sits gently under the urethra without riding up the sides. It is fundamentally less obstructive.
Got it.
It provides the backboard for when pressure spikes, but it doesn't compress the hose nearly as much during normal urination.
So what does this mean for you, the listener? Like if you are analyzing this data or maybe for a patient sitting in a doctor's office trying to make a decision, how do they choose between the U and the V?
Well, it all comes down to a physiological test called urodynamics. Before surgery, doctors measure a patient's natural urine flow rate and the strength of their bladder muscle contractions.
Oh.
If a patient already has a weak flow rate, like maybe their bladder muscle isn't generating much squeezing power anymore, you really do not want to put a highly obstructive U-shaped TVT sling in there.
Because their weak bladder muscle wouldn't be strong enough to push fluid past that sharp kink.
Exactly.
Pushing them into full urinary retention where they'd need a catheter.
Precisely. So for patients with pre-existing low flow rates, the less obstructive, flatter V-shaped TOT sling becomes the much safer preferred choice.
It is genuinely fascinating that the exact same material, hung from different anatomical trees, alters the fluid dynamics of the body so drastically.
It really is.
But we can't let the TOT off the hook completely here, right? It solves the abdominal risk. You no longer have to worry about a needle poking holes in the bladder.
True.
But navigating out laterally through the groin must introduce a completely new set of structural hazards. You're just moving to a different neighborhood, and the new neighbors might not like the construction.
That's a great way to put it. The new neighbors are definitely sensitive. And as experience with the TOT grew over the years, surgeons realized there were actually two distinct ways to route the mesh through that obturator space in the groin.
Okay, two different routes.
Yeah, this led to a split in the surgical technique itself. We have the outside-in approach versus the inside-out approach.
Walk us through the physical mechanics of those two paths. How are they different?
Okay, so the outside-in technique means the surgeon starts from the outside of the body. They make an incision in the crural fold of the thigh, which is basically the crease where your inner thigh meets your pelvis.
Right.
They use a specially designed helical trocar that looks a bit like a corkscrew. They pass it from the thigh, push inward through all those layers of groin muscle in the obturator membrane until the tip reaches the vaginal incision to grab the mesh and pull it back out.
Okay. And the inside-out method just reverses that traffic.
It reverses the direction entirely. The surgeon uses a winged guide, starting at the vaginal incision, right under the urethra, deep inside the pelvis, and they push the trocars outward.
So driving from the inside to the outside.
Exactly. Driving through the obturator space from the inside until the needles exit the skin in the groin crease.
But mechanically speaking, why would a surgeon even care which direction the needle travels if it ends up in the exact same spot? Does the direction really change the structural outcome?
It does, actually. It creates highly nuanced differences in the tissue architecture. The sources note that the outside-in slings tend to hug the pubic bone a bit more closely on their journey.
Okay.
Meanwhile, the inside-out method was specifically designed to minimize the dissection of vaginal tissue.
Let's focus on that for a second. Why does minimizing tissue dissection matter to the patient?
Well, every time a surgeon cuts or dissects tissue to make a pathway, the body has to heal that tunnel. That means inflammation and eventually scar tissue.
Right, the body's natural response.
The inside-out method aims to disturb less of the delicate tissue directly surrounding the urethra itself, theoretically lowering the risk of urethral injury or excessive scarring right where the backboard is supposed to function.
That makes sense. But regardless of whether you go outside in or inside out, you are passing a needle and leaving a permanent mesh tape inside that obturator foramen. What are the actual anatomical risks of this new neighborhood?
This is where surgical anatomy gets incredibly precise and, frankly, a bit daunting. The obturator region is not empty space.
It's not just a blank void.
No, it is densely packed with crucial nerves and blood vessels that serve the leg. When a TOT sling is placed, studies on cadavers show it passes, on average, just 1.1 centimeters from the most medial branch of the obturator vessels.
Wait, 1.1 centimeters, that is less than half an inch of clearance.
I know. It is a razor-thin margin of safety. And the mesh passes just 2.8 to 3.4 centimeters from the anterior and posterior divisions of the obturator nerve.
That is incredibly tight, even if the needle doesn't directly hit the nerve during the surgery. What is the mechanism that causes a problem if the mesh is resting that close to a major nerve long term?
We have to remember that the mesh is a foreign body. As the body heals around it, fibroblasts rush into the area, creating a capsule of scar tissue around the polypropylene fibers.
Which causes inflammation.
Exactly. It causes an inflammatory response. Tissues swell. If that swelling and scar tissue formation happens mere millimeters away from a major nerve, that tiny 1 centimeter buffer gets eaten up very quickly.
Wow.
The inflamed tissue presses on the obturator nerve, compressing it or irritating it.
Which I'm guessing sends pain signals radiating down the leg or groin.
Exactly. And because of this proximity and the subsequent inflammation, the TOT procedure carries a higher risk of postoperative groin pain. Interestingly, the data shows this risk for chronic groin pain is slightly higher with the inside-out technique specifically.
Is that because of the angle?
Likely, yeah. Because of the exact trajectory the needles take past those nerve branches as they exit the pelvis.
So if we look at the grand ledger of risks here, we are essentially trading the risk of a punctured bladder in the abdomen for the risk of nerve irritation and chronic pain in the groin.
That's the trade-off.
It really highlights the hard reality that there is no such thing as a completely risk-free surgery.
There really isn't. I mean, the vessels in the obturator region are generally of a smaller caliber than those in the retropubic space. And it's a confined muscular area, so massive, life-threatening bleeding is less likely.
Right.
But that proximity to the nerves is a real structural reality of the TOT that patients just have to be monitored for.
This has been an incredible journey through pelvic physics and anatomy. Let's recap the core structural differences for you, just so you have this locked in.
Sounds good.
We started with the TVT, the tension-free vaginal tape. It takes a vertical retropubic route going up behind the pubic bone to anchor in the lower abdomen.
Right.
This creates a steep, distinct U shape. That steep shape can be obstructive, like a kinked hose, and the blind upward surgical path carries the risk of injuring the bladder, the bowel, or major abdominal vessels.
Yep. And we contrasted that with the TOT, the transobturator tape.
Yeah.
It avoids the abdominal minefield entirely by taking a lateral route, passing out through the natural openings in the pelvic bone into the groin.
Creating a completely different shape.
Right, this lateral anchor creates a flatter, shallower V shape. That shape is far less obstructive, making it much better for patients who already have weak urine flow. But its path brings the mesh within millimeters of the obturator nerves, introducing the new inflammatory risk of postoperative groin pain.
So why does all of this anatomical detail matter to you?
It matters because it perfectly illustrates the absolute necessity of personalized medicine. We so often fall into the trap of thinking about a surgical fix as a one-size-fits-all product.
Right, like ordering a part for a car.
Exactly, but it's not like that. Here, a patient's specific physiological anatomy, their urodynamic flow rate, and even how much scar tissue their body tends to produce, dictates which spatial geometry, the steep U or the shallow V, is the safest and most effective choice.
It's all about context.
A surgeon literally has to weigh the mathematical risk of a bladder perforation against the risk of nerve compression for every single individual sitting in their office.
It really makes you appreciate the intense mechanical engineering that goes into these procedures and how doctors have to treat the body like a complex architectural site.
They absolutely do.
Which leaves us with a final thought to ponder. We just spent this entire deep dive seeing how the exact same material, a simple strip of inert polypropylene mesh, can have completely different side effects, solve different physiological problems, and create vastly different risks solely based on the geometric angle it creates inside the body.
It is entirely about where you place the anchor points and the physics of the shapes they create.
Right. So it makes you wonder, what other permanent medical implants in our bodies, cardiac stents, joint replacements, spinal fusions, or pacemakers might act completely differently or perhaps perform even better if we simply shifted their anchor points by just a few degrees. When you are hanging a hammock in the dark, finding the right trees doesn't just change the view. It completely rewrites the tension, the stability, and the impact on the entire yard.